Good afternoon, everyone, and welcome to today's webinar on advanced heart failure in adults with a Fontan circulation. Thank you for joining us. My name is Dr. Kate Kearney, and I'll be co-moderating this session with Dr. Neha Bansal. Before we begin, just a few housekeeping things. This will run for an hour. Please submit your questions anytime using the chat feature, and we'll address them at the end or in the chat as we go. Aiming to have a final 10 or 15 minutes of Q&A if possible, and just let us know if you have technical issues through the chat as well. Yeah. Our first speaker, so we'll begin with a core review of the anatomy and physiology of the Fontan circuit, follow with a discussion of recognizing Fontan circulatory failure and when to consider referral, and wrap up with options for advanced therapies, including transplantation. And it's my pleasure to introduce our expert speakers for today's session. Our first speaker is Dr. Anitra Rumpf. Dr. Rumpf is a clinical professor of pediatrics and of medicine and cardiovascular medicine at Stanford University and practices in the adult congenital heart program there. Her clinical focus is on adult congenital heart disease, heart failure, and pulmonary hypertension, and she's contributed extensively to research on those. Dr. Rumpf, thanks for joining us today, and the floor is yours.
I'm just getting my slides here. Just one moment. Okay, can you see my slides? Yes, okay, great. So yeah, it's my pleasure to present to this very sophisticated audience, so it'll be very basic, on anatomy and physiology of the Fontan circuit. And I'm my many thanks to ISHLT Pediatrics Professional Society and ACHD communities. It's very much an honor for me to be part of this group. So the goals of this talk will be to know the anatomy and physiology of Fontan and various lesions that lead you into the club, and then also to know the physiology of the Fontan circulation, and through that we'll understand the systemic effects of the Fontan circulation on the rest of the body. The various defects will lead to Fontan palliation. In the simplest sense, it's the absence of two well-developed ventricles or a single ventricle. So you can see here, sometimes its ventricular morphology is more like a dominant LV, sometimes it's a dominant RV, and sometimes that there's indeterminate type of ventricle exhibiting single ventricle physiology. In other cases, we may have two well-formed ventricles, but septation is simply not possible. So in this example here, you can see double inlet here into a predominant LV, and there's also double outlet ventricle right here with a non-committed VSD. And then lastly, the other way to get into the club is if there's only a single outlet present, for example. And so diving a little bit into a very common lesion that leads to a single left ventricle is tricuspid atresia. Many of you are familiar with this, that the RV lacks an inlet. The RV is very small and thick-walled in the setting of an intact ventricular septum, a little less so if there is a VSD present. And 2/3 of cases have concordant VA connections. On the other hand, a single right ventricle that we typically think of in terms of physiology would be hypoplastic left heart syndrome. And this can have various flavors, right? It can be mitral atresia that's associated with aortic atresia or stenosis. You can have mitral stenosis and aortic atresia. So there's various subtypes, as you can see in these diagrams here. Sometimes there's the mitral valve doesn't form at all, so mitral atresia, or it's imperforate, or it is very small, associated with a small LV. So there can be definitely a spectrum here with hypoplastic left heart. And then lastly, a common one would be double inlet left ventricle, where we have two valves that open into a single left ventricle. Sometimes one valve similarly is imperforate, but essentially you have single ventricle physiology there as well. And lastly, we talk about this functionally univentricular heart. So this is the examples here are things like Epstein anomaly, where you have a large atrialized RV and really a rudimentary RV that's not sufficient to support a circulation. And you can see this in PAIVS as well, or other types of lesions. And that's going to also lend itself to single ventricle palliation through a Fontan. So what's the problem here? Obviously, the problem of single ventricle physiology is that you have mixing of systemic and venous circulations in a single ventricle. So one main ventricle is pumping to both pulmonary and systemic circulations in parallel. And in the absence of anatomic restrictions, it's really the balance of PVR and SVR that will govern flow to the lungs, QP, or flow to the body, QS. So staged palliation is needed because there's changing physiology in the neonate. For example, PVR dropping from birth to 6 to 8 weeks of age. So it's not that the palliation can be done in one fell swoop, as everybody knows. So this is very much a staged palliation for the adult colleagues in the audience to realize in the past medical history. So really the goal of stage 1 palliation then, what's the solution? We talked about the problem, what's the solution? Is really to establish unobstructed pulmonary and systemic venous return, unobstructed pulmonary systemic outflow, and limit blood flow to the lungs to result with normal pulmonary pressures. So you can see in this diagram here, nicely outlined and taken from one of the textbooks that with single ventricle anatomy, you can have problems where you are ductal dependent to your pulmonary circuit, where you are ductal dependent to your systemic outflow. You can have a situation where nothing is obstructed and nothing needs to be done initially as stage 1 palliation. And then you can have unobstructed systemic blood flow and pulmonary blood flow. So that's sort of unregulated there. And so how do we sort of go with these goals and these solutions for each of the various lesions? Well, it's fairly straightforward in the sense that if you have ductal dependent pulmonary circulation, well, you need to establish a more robust way to take blood to the lungs. So for example, here you can see various types of shunts, systemic aorta to pulmonary shunts. So essentially taking this red blood, putting it back into the deoxygenated blood so that it can be oxygenated in the lungs, and hopefully that will promote growth of the pulmonary arteries, for example, if there's insufficient growth or that needs to happen. Keep in mind that's very important, right? Because when we ultimately get to the Fontan, we need adequate arborization of our pulmonary artery tree, our growth of our lungs, and that type of thing to keep PVR low, because flow to the lungs will depend on a low PVR state. Okay, what about the situation when we have too much pulmonary blood flow? Well, too much, we need to restrict it. So you can see here that the stage 1 palliation in that case would be pulmonary artery banding. So try to limit pulmonary blood flow so as not to flood the lungs, so as not to drive up PVR, so that we can get to that happy place ultimately when we want to go to the Fontan palliation, where there's a low PVR to promote blood flow to the lungs. And lastly, what about the situation where we have ductal dependent systemic circulation? So in other words, as that PVR falls, blood will want to go more to the lungs. You'll have less blood flow to the body, and there can be resulting in shock. So we need to construct a stable systemic outflow. For example, the stage 1 Norwood or hybrid stage 1 rather, in the case of insufficient systemic blood flow. So this is a diagram showing amalgamation of the PA to the aorta so as to construct a nice outflow, systemic outflow. And then, of course, we would establish a proper source of pulmonary blood flow, either through a sono or a systemic to pulmonary shunt, as I showed earlier. So now that we reach the goals of stage 1 palliation, when can we start to think about stage 2 palliation. In other words, a more stable source of pulmonary blood flow. Because remember, after the stage 1, we, of course, suffer from still chronic desaturation. There's still complete mixing of systemic and pulmonary return. So saturations are lower. And if we stay in that first state, there's chronic volume overload of the single ventricle, because that single ventricle is still trying to support a pulmonary and systemic circulation. So the solution then is to consider Glenn, or a cavo pulmonary anastomosis, where the SVC is surgically connected to the pulmonary artery. And this way, especially in a younger child. So this may be done, say, as early as, say, 4 months up until 9 months. So we have a wide window there. The most important thing is that pulmonary vascular resistance has fallen. Likely, there's good arborization of your pulmonary tree in order to make this happen, so that we can have passive blood flow from the upper half of the body going to the pulmonary arteries. So the solution with this, Glenn, then you have improved systemic oxygenation. It's not perfect because, remember, we still have IVC, systemic blue blood, mixing with our oxygenated blood that came from the lungs. You do establish a stable source of pulmonary blood flow, and this reduces overload in the single ventricle. And remember that in a younger child, you have more big head, small body, as I like to say with, neonates and toddlers, so that more blood flow, you're actually unloading more than you would, say, in an adult where there's less blood flow going on the top half of the body. So at least 50% reduction, and that helps that ventricle out that was pumping 2 circulations. Okay, now now that we've talked about those 2 staged palliations, we come to the idea of a Fontan. And there are different flavors of Fontan. Atrial Fontan is the oldest that we may see floating around in our clinics, in our adult clinics nowadays. And with this palliation, the idea was that we say, now what do we do with the IVC blood? We want the atrial appendage. What if we use the atrial appendage to divert systemic blood flow to the pulmonary arteries? Maybe the rugae of that appendage can help us pump some of that lack of subpulmonary pump that we were not born with, and help divert that IVC blood and SVC blood to the pulmonary arteries. Unfortunately, that did not totally come to bear, in that, unfortunately, it was found that because we retain this connection with the heart, you do get dilation of that atrium, and a big boggy atrium at that. And you do result in early arrhythmias and thrombus due to sort of inefficient flow, because all this becomes dilated, and that what we hoped to help us pump blood to the lungs actually ends up dilating along with the heart. So that's the AP Fontan, or atrial pulmonary Fontan, because it's the right atrial appendage to the pulmonary artery. So that's how you can remember it. So then another iteration of Fontan that you may see is the lateral tunnel Fontan. And in here, remember, we already established the SVC to the cavo pulmonary anastomosis here. So now we need to how will we divert our IVC blood? The IVC blood is diverted through the heart, to the pulmonary arteries. And this avoids that atrial dilation that we experienced in the AP Fontan. And that has improved efficiency flow to the lungs. So this can be seen in many of our patient populations now, as young adults and adults, depending on the center that you're in. And then lastly, the other flavor of Fontan that's commonly seen now, remember I told you that AP Fontans are going to be phasing out now, only in the older adult population. And now we will start seeing either lateral tunnel Fontan or extracardiac Fontan, as shown in this picture. So here the idea is, well, wait a sec, let's divorce ourselves completely from that heart, so as not to hopefully not promote arrhythmias and things like that. And let's go extracardiac, in other words, outside the heart, and divert that IVC blood through a graft or tube to send that blood directly. So that this Fontan overall, this and the lateral tunnel, now commonly seen, you can see that we've achieved a nice goal. We have separation of the circulations. We should be nearly fully saturated. I say nearly because there's coronary sinus blood flow, so it's not perfect. We reduce the work on the ventricle, so avoid that dilation. And we're making up for the fact that we lack a subpulmonary pump. And as I tell my patients, we're using the pump that you were blessed with to pump to the body. So what has happened then with the resultant Fontan physiology over time? So I give you this diagram here, which everyone has seen, I know, in various forms in physiology texts. Here is the normal circulation, biventricular circulation in series. Remember, we started out in parallel with the Fontan, with the single ventricle at birth. So this is now in series in a normal heart. How would it look? So how can we make our Fontan look like that? Well, here is our physiology diagram. So we have the ventricle, we have the aorta, and here is our central venous pressure here, which is the same for our adult colleagues. Central venous pressure and Fontan pressure are identical, also equal to pulmonary artery pressure. I know many of you in ISHLT are part of a listing for patients who have heart failure and so on. And we often talk about central access. It is central access if it's in the Fontan, just as a side note. But you can see here now we have the systemic venous blood pressure, the venous blood pressure of the Fontan driving that blood across the pulmonary bed. And it's by necessity, of course, it needs to be higher than the end diastolic pressure of the heart. But what happens over time? Unfortunately, as EDP rises over time with age and whatnot, our central venous pressure also must rise. So you can see that this level is quite a bit higher than that we would experience in a normal biventricular circulation. This lends itself to a lot of the physiology that we see then in the adult patient. So some of the systemic effects of the Fontan here, you can see with these elevated venous blood pressures, sometimes the body will form the various collaterals sometimes as pop-off. Sometimes these will be SVC to IVC, so systemic blood to systemic blood to try to pop off that higher pressure. Sometimes it will be systemic to pulmonary. This represents a right to left shunt. For example, it could be blue blood coming from the SVC to a right pulmonary vein, for example. So that will cause desaturation. Remember, I said we have nearly normal saturation. So we start to see that. We start to suspect that maybe there's these systemic to pulmonary collaterals. You can also get AP collaterals, which don't change the circulation, but will volume load the ventricle. And in some patients, they may either have a fenestration that was left open, which is an obligate right to left shunt, or one may be made in order to sort of decompress. And that unfortunately does have a stroke risk and does, because it's an obligate right to left shunt, will cause cyanosis. Other things to watch for are obstruction to inflow and outflow. For example, with growth of the patient with an extracardiac Fontan, has that Fontan tube become too small from age of 3 where it was put in to adult world. So all that comes into the physiology then. And so complications of having a Fontan will flow from this, which my colleagues will elaborate on more. But essentially, we talked a little bit about some of the post-Fontan complications here. Because we have passive blood flow from the systemic to the lungs, we need a situation where we have low PVR. And because it's passive blood flow, then there's no pump. We do have risks for thromboembolism here and endothelial dysfunction and back pressure on causing Fontan-associated liver disease, causing renal dysfunction, causing, we have osteopenia, we have elevated, we have glucose intolerance, we have muscle mass complications and things. So all of these stem from the central problem of we lacked a subpulmonary pump. So this palliation was sort of the best to get us to this point. But now we have to recognize it's a systemic disease that we're dealing with. And that's it for my portion of the presentation. And my colleagues will take over with some of the next steps. Thank you.
Thank you so much, Dr. Rolf. That was a great overview of Fontan circulation. And we're going to be moving to our second talk. But just before we do, I wanted to introduce the ISHLT ACHD Special Interest Group that was created a few months ago. If you are interested, there's an ISHLT Connect group for all the people. The hope is that there would be more robust sharing of ideas and conversations. So I would like to introduce the next speaker for this webinar. And if you guys are interested in the special interest group, I'll put it in the chat so you guys can go in there and connect. So it's my pleasure to introduce Dr. David Crossland, who's a consultant pediatric and adult congenital cardiologist at Freeman Hospital in Newcastle in UK, where he also serves as the clinical lead for congenital heart services. He has published on heart failure in adult congenital patients and on combined heart-liver transplantation strategies for failing Fontan physiology. He will guide us through signs and symptoms of Fontan circulation failure and considerations for referral for advanced therapies. Dr. Crossland, please take it away. Thank you.
Thank you for the introduction, and thank you for asking me to talk today. So I suppose the first question is, who are you actually referring your patients to? And how's their program set up? So in Newcastle, we work at the Freeman Hospital, which has a model of combined pediatric and ACHD centre. We have combined pediatric and adult heart transplant program, and we carried our assessments and listing by the ACHD team, and it's the congenital team that takes ownership of these patients. But several different models exist, and you can see that our numbers of congenital heart disease patients we've transplanted in adults is now competing with the non-congenital patients. And so what are the advanced therapies that you are referring for? Originally, I was going to put a slightly more controversial title to this slide, which was going to be, does your heart failure centre actually do Fontan transplant? And the reason for that is that if you're referring patients to a centre which doesn't offer heart transplant for Fontan patients, is the patients are simply going to get turned down for that therapy. And this is our programme for over the last nearly 25 years. And it looks like not a lot of work. It's only 53 transplants and 154 assessments over nearly a 25-year period. But the work extends well beyond this, and Nicola's going to cover this in more detail. But there are several other aspects to the service. And particularly importantly, this includes support for patients with no further option and helping with that decision and the whole of life planning for those patients. So what I'd like to show you, and I'm not going to show you because the data doesn't exist, is an evidence-based guideline to which patients you should refer for transplant and other advanced therapy. These are the UK guidelines for referring patients for transplant who haven't got congenital heart disease. And each of these bullet points is evidence-based. So you can use peak VO2 max, for example, to predict the time into death in patients with cardiomyopathy, and all of the other aspects of that have equal evidence base. And you can easily find equivalent guidelines for other organ donation systems. But I haven't got that for Fontan patients. So perhaps the first thing to do is look at lessons that we've learned from post-transplant survival. So in 2017, our first 26 Fontan transplants, we looked at how they did following their transplants, and we divided at the time the patients into those with impaired ventricular function and those with preserved function. I wish in retrospect we divided them into isolated impaired ventricular function and everything else, but this is how we did it at the time. And what we found was that the patients with everything else, with true Fontan failure as opposed to isolated impairment of ventricular function, did quite poorly. And these are 3 echocardiograms showing an excellent function of a transplanted heart, and these echoes are taken within 24 hours of those patients dying. And we found that these patients were dying of what in 2010, and I am not surprised, although slightly disappointed that the term FAFO didn't take off across the world. But what we found was that they were dying of all the reasons we were transplanting them for in the first place. So all of the multiple elements of Fontan failure continued after the heart transplant. And as a result of this, we've of course changed our peri-transplant management, but that's going to be talked about later. But one of the key messages that we gave here was to refer patients earlier. This is outcome following transplant from a multi-center study looking at pre-transplant variables associated with mortality. There's some caution with this data because the total number of patients transplanted per center is quite low, and there were some patient-specific risk factors found. But again, patients presenting with heart failure and referred late were the patients who didn't do very well. And so again, the message from that paper was to refer earlier. However, it's difficult to use the data like this because maybe we should be using data on post-transplant mortality to decide who we shouldn't transplant as opposed to who we should transplant. So the Fontan failure is interlinked and a multi-system disturbance. High pulmonary vascular resistance, low cardiac output, and high central venous pressure from multiple factors. And it's a very difficult diagram to draw because the interlinking between all of these areas is so profound. So high pulmonary vascular resistance causes low cardiac output. Low cardiac output can lead to atrial arrhythmia. Arrhythmia can lead to low cardiac output. So every part of this diagram is linked. So I still haven't got the answer for you of which patient should be referred and what the exact problems are. But there is some data. This is a photograph of a cast produced by an older teenager with severe plastic bronchitis who presented with life-threatening cyanosis related to airway obstruction. And plastic bronchitis is a recognized form of Fontan failure, has protein-losing enteropathy. And you can see from this data of 55 patients from the New Zealand Fontan registry that from onset of protein-losing enteropathy or plastic bronchitis, there's a high mortality. The slight problem with this is that mortality at 2 years is not quite 20%. And of course, the majority of the main indication for transplant is a 2-year survival estimated at 50%. So these patients, just at presentation with plastic bronchitis or protein-losing enteropathy, shouldn't necessarily be referred for transplant. But there are multiple other Kaplan-Meier curves that I could show related to recurrent arrhythmia, NYHA status, degree of AV valve regurgitation, saturations, the development of ascites, other biomarkers, and deterioration of ventricular function. And these in combination can be used to try and decide who is at risk of death and who we should consider transplanting. We can combine this with more standard adult congenital heart disease risk factors. It's well recognized, and I've already alluded to this previously, that a single admission with heart failure in adult congenital heart disease patient it significantly increases your risk of dying. And this paper from Professor Roche showed us very clearly that patients with adult congenital heart disease who are more symptomatic are more likely to die soon. So with the lack of data, the action group came up with this schema of consideration for advanced heart failure consultation in those with a Fontan circulation. And you can see that a combination of Fontan pathway dysfunction, problems with the systemic circulation, and the fallout from those lymphatic dysfunction and extracardiac dysfunction should lead to consideration of referral for advanced heart failure management. There are some caveats to this. I accept that I haven't really demonstrated exact cutoff curves for death within 2 years from all of these things, but you can see from the data I've shown that when they're present in combination, then death within 2 years becomes more likely. The patient should be referred earlier if there's a risk of loss of candidacy, so particularly Fontan-associated liver disease and protein-losing enteropathy can come to the point where the patients become untransplantable, although are likely to survive for more than 2 years. Particularly with Fontan-associated liver disease, worsening hepatic function might mean that you need to consider heart-liver transplantation, and in the UK it's extremely difficult to deliver that. Assessments might be long and complex, and long and complex assessments obviously need more time, and so early referral is needed. In some patients, you might be considering other options, so particularly AV and VA valve replacement. And I think one of the things that ACHD cardiologists across the board made a mistake doing 10 and 15 years ago was when we were considering Fontan upgrades. Many of those patients underwent Fontan upgrade without parallel planning with transplantation. Many patients are HLA sensitized, particularly those with hypoplastic left heart syndrome when a homograft has been used, and those who have undergone pregnancy. And finally, patients might have other comorbidities that are going to affect transplant, and patients simply want to plan their lives and know what they're suitable for. And these are often non-Fontan associated problems, their BMI, but they've also got underlying lung disease and associated psychological issues. And finally, I think it's important to avoid turning down patients without referral for advanced heart failure management. Many adult congenital heart disease centres are able to mitigate some of the published risk factors with optimization, with catheter procedures and changes in medical therapy. I think there are probably two main barriers to improving outcomes and transplanting more Fontan patients. I talked about the way we developed our team at the start of this presentation. This is how our team looks now. Everybody is in the room. Everybody is essentially paid to be there. And the team was developed as part of a heart failure transplant team for Fontan patients. But there's one group missing. I think when you're referring patients, then you should be part of this team. You should be within the team, even if you're not within the centre. You should be doing joint clinics, outreach clinics, joint MDCs, and together making timing decisions about when patients should be transplanted. So sit in the room and turn your cameras on. And the second barrier is historically adult congenital heart disease patients on the transplant waiting list have been disadvantaged, and they've been disadvantaged at every step of the pathway. This shows adult congenital heart disease patients prior to 2016 from the UNOS database, and you can see that adult congenital heart disease patients listed status 1A and adult congenital heart disease listed status 1B are far more likely to die or be delisted than their non-congenital counterparts. Now, my understanding is that this has changed significantly since the UNOS updated their heart allocation systems in 2018. But in other organ donation systems, this hasn't happened and certainly remains a problem for us in the UK. But if we are going to plan for earlier referral, earlier assessment and earlier listing, it needs to be synonymous with earlier transplantation. And there will be the ongoing problem of a hemodynamically stable Fontan patient who is gradually losing candidacy being compared to a crash and burn dilated cardiomyopathy patient on temporary mechanical support. So in conclusion, are you certain that the team you're referring to is able to offer advanced therapy and transplant? Progressive symptomatic Fontan failure, in particular patients who required admission, are key determinants of the timing of referral. I haven't got, as I said at the start, the availability of precise timing indications for you, but patients should be discussed early, and it's important to be part of that discussion. And we need to continue to work with organ allocation systems to allow appropriate transplant timing in Fontan patients. Thank you.
Thank you so much for that, Dr. Crossland. That's a highly informative overview of clinical red flags and practical considerations for when to escalate care in Fontan patients. With these concepts in mind, we're going to transition to therapeutic options. So our final speaker is Dr. Nicola Pratigan, who's a cardiac surgeon from the University of Padova in Italy, clinical and research involvement in advanced heart failure therapies, including transplant, and emerging technologies in mechanical circulatory support for complex congenital heart disease. Dr. Pratigan will discuss the options and considerations for advanced heart failure therapies for patients with Fontan failure, including transplant, MCS, and emerging technologies. So thank you, Dr. Pratigan. Take it away.
Good afternoon. Thank you very much. I'm really glad to present today this topic on such an interesting aspect of the failing Fontan. As David said before, failing Fontan is not just the heart. Failing Fontan and advanced heart failure means a lot of aspects of the failing Fontan pathway, which by the end led to advanced heart failure and the need for consultation. And so today we will talk not only about heart transplantation, but we will mention transcatheter procedures, Fontan conversion, the role of mechanical circulatory support, both short-term and long-term, even if I don't think that long-term in this case is the right word. And then just a couple of words regarding future options such as biventricular conversion and xeno. So when we talk about transcatheter therapies in failing Fontan, of course, we talk about supraventricular arrhythmias, which especially in AP Fontan represent an important point to manage to reduce the risk of death as well as the risk of transplantation during Fontan follow-up with nearly 85% of freedom from these endpoints by 5 years after ablation. But of course, the main part of transcatheter therapies is represented by the management of Fontan pathway obstruction, such as stenosis in the vena cava, anastomosis, or stenosis in the pulmonary artery, which of course represent an important step to improve the clinical symptoms of patients. But by the end, it's just a palliation if we consider the last endpoints. If you see in the study, we had an improvement, even if in a small number of patients, of the functional class of patients. But these procedures did not change the liver fibrosis scores, as well as the spleen size or the platelet count. A different point is represented by collateral vessels. You know that collateral vessels, both AP and VV, represents a nightmare for transplantologists, for cardiac surgeons. But of course, the management of these collaterals before transplantation can have a significant impact on bleedings intraoperatively, as well as the number of blood and plasma units used during these procedures. Other transcatheter therapies, such as lymphatic disease management, percutaneous Fontan fenestration, which is still controversial, or transcatheter edge-to-edge repair for systemic AV valve regurgitation, are represented by isolated case reports. Just a few words regarding Fontan conversion. In the last decades, especially pediatric cardiac surgeons and congenital cardiac surgeons collected a lot of data regarding the Fontan conversion, also known Redu Fontan. But I think for a transplantologist, this interesting paper recently published in Circulation Heart Failure in December 2025 definitely, I would say, summarize what probably Fontan conversion represents nowadays. In fact, in this study, you see no difference in terms of the death plus transplant endpoint compared to the AP Fontan. But when compared to the extracardiac conduit, of course, we have a significant difference between the two groups. And even if the Redu Fontan does not impact compared to the AP in terms of death and transplant risk, there are other factors which are related to the risk of death and transplantation, especially the increasing age of Fontan patients. Talking about mechanical circulatory support, we start from ECMO, which is, of course, the first step, especially in acute ill patients with worsening systolic dysfunction. We know that univentricular has worse survival than other congenital heart disease, and it has a worse outcome, especially when it is used as a bridge to transplant. Close to ECMO, we can also consider microaxial flow pump, Impella, both the CP, the 2.5 and the 5. But of course, again, these are just case series as the one that I'm showing you here. Of course, we would like to have a direct transcatheter Fontan circulation support, which to date does not exist in the clinical scenario. But there are a lot of preclinical prototypes which lack design problems, but probably in the near future might be a solution to rehabilitate the Fontan circulation. Regarding the long-term mechanical circulatory supports, we can talk about continuous flow or pulsatile flow systems, the paracorporeal, both the Centrimag or the Berlin Heart cannula, or the intracorporeal LVAD, like the hardware or the most recent HeartMate, both in ventricular position or in atrial position, as you can see on the right. This has been described in few cases for low weight patients. how to choose patient weight, ventricular size, device-related ventricular unloading abilities, as well as the ability to promote flow through the Fontan circuit. But if we look at the results of the preliminary results of both paracorporeal and intracorporeal device, you see that in this study from the STS with both Intermax and Pedimax data, we just reached the 1-year follow-up, and even if results are promising with an increasing number of VAD implanted, what it's worse is the fact that more than 90% of patients were crashing Intermax 1-2, with 29% of them already on ECMO, and probably we can do better in terms of referral of this patient. Similarly, data from ACTION shows similar data. Again, we don't have enough data regarding a long-term follow-up for this device. As you can see, this recent published manuscript just show a very limited case series of hardware, HeartMate 2 and 3 at very long-term follow-up. Regarding MCS with preserved systemic ventricular function but failing Fontan circulation, this represents a challenging population. In the last years, X-core cannula from Berlin Heart came out, but we are still at a preclinical setting for finding the perfect design for this condition. And when we have both systemic ventricular dysfunction and failing Fontan circulation, we might consider both Berlin Heart BVAD, or there are some cases of a total artificial heart syncardia, but of course you can imagine very complex procedures. Heart transplantation is an emerging and increasing procedure, but unfortunately, I think heart transplantation is not for every failing Fontan. Here in one of the largest cohort of patients, more than 500 patients studied in these studies from Annals, you see that age and preoperative risk factors represented risk factors for both mortality and comorbidities. And so probably these are important points that we have to rule out when we perform the checklist of patients, the workup before transplantation, with a particular focus, of course, on the immunological status of these patients, which are frequently sensitized, and the technical aspects, which are very important for surgeons, like facing problems like dextrocardia or other additional problems, especially related to previous cardiac surgeries in the patients, which might affect the outcomes of heart transplantation in adult congenital heart disease and Fontan, which unfortunately to date is aggravated by a high 30-day mortality, 20%. When we look at early and long-term follow-up of univentricular heart transplantation, you see that, of course, you have a worse survival compared to biventricular, with a 10 years, 50% of survival, with multiple factors which can affect both in terms of age of referral, presence of collaterals, presence of FALD, as well as the intraoperative aspects. And all these aspects must taken into account when you decide to list a patient for heart transplantation. Of course, it's not just a matter of FALD, it's a matter also of the type of circulatory failure that you have that can, by the end, affect the outcome also of the heart transplantation. But this introduces another important aspect, which is that of FALD, the liver disease associated to Fontan. And this is important because nowadays, more and more, there is interest in considering patient not only for the transplantation of heart, but to consider combined heart-liver transplantation in a specific subset of patients. This is one of the most recent cohort studies in which you see how patients were listed for and transplanted both for heart and liver show longer time from Fontan completion, show longer, of course, cardiopulmonary bypass times, longer hospital stays, and trend toward longer ICU stays. But when we look at adjusted 1 and especially 5 years follow-up outcomes, you see a benefit of the combined heart-liver transplantation. However, the mechanisms included in these are still to investigate. There are longer follow-up with the combined heart-liver transplantation, especially in this cohort of study over 2 decades, with I would say excellent survival outcomes at 18 years of follow-up. And another aspect which probably will require in the future additional studies is that of liver transplantation before heart in sensitized patients, with really promising results, at least in this very small cohort of patients. And last but not least, two aspects which I guess will take the floor of failing Fontan in the therapeutical options of advanced heart failure. Biventricular conversion. There is a small cohort of patients from Boston in pediatric patients, around 10 patients, which in specific anatomical conditions underwent biventricular conversion. In adults, we still have very limited case reports like the ones from JTCVS techniques. But you see how complex these strategies are, and we don't know exactly how this change will actually affect how the heart will adapt to the systemic and pulmonary circulation, and xenotransplantation, which is still, of course, ongoing. So in conclusions, advanced heart failure in Fontan can be managed with different strategies to increase freedom from transplant death. Transcatheter therapies are efficient in optimizing Fontan circulation, but unfortunately are just palliation and bridge to future treatments. Fontan conversion does not give an advantage on survival freedom from transplant. Short-term and long-term MCS are emerging with still too early outcomes and limited use in very advanced patients. Heart transplant is the gold standard with high in-hospital mortality, but acceptable long-term outcomes. And I think that emerging issues with combined heart liver transplant will give us very interesting information in the future. And regarding xeno, the future of transplantation, I just cite Professor Shumway, who was used to say, xeno, the future of transplantation, and always will be, with a question mark. Thank you very much for your attention.
Thank you so much, Dr. Pradigan, and thank you to all of our speakers for such comprehensive presentations on a really complex topic in a really short time period. Well done to all of you. We're now moving to the Q&A segment, so please put your questions in the chat. I might kick off in the absence of seeing any at the minute. Dr. Rumpf, when you think about Fontan failure, what is the most common physiologic misconception you see amongst non-ACHD clinicians?
Yeah, thank you for that question. I think one of the biggest things is treating them like regular heart failure patients, looking at a single VO2, for example, and piling them in with biventricular circulatory failure, as was alluded to by other speakers. We and many in the ACHD community tend to follow trends where the patient is his or her own control, so that we have some objective data. And we caution the use of NYHA class because similarly, patients become adapted, as this very sophisticated audience knows, becomes adapted to their own disability. So they may not know anything different. But yeah, I would say that trying to treat them like regular heart failure patients, also failing to assess the systemic effects is pretty common. And we often have to remind the implications of the earlier surgeries and palliations on the present anatomy. But yeah, VO2 doing a single number and judging a single thing from it tends to be the biggest pitfall.
I don't see any other questions yet, but Dr. Crossland, I was curious about how you beautifully presented your multidisciplinary team, how you've developed. What do you think would be the key lessons, that you've learned and would like pass on to other people who are trying to set this up, especially because some of these patients have longstanding relationships with their pediatric cardiologists, and now they're coming into the ACHD world, which is a little bit different. So just wondering, your thoughts on continued collaboration.
It is difficult because we, partially by design and partially by default, have this system where everything's on one site. And so we started off transplanting children and then children with congenital heart disease before I started, and then gradually moved on up to the adults. Whereas there's going to be so many Fontans that we probably do need more centres. So for me to say, your centre has to be transplanting Fontans is slightly disingenuous, because some more centres are probably going to have to start at some point, or at least develop their teams. The most important thing is not to be firefighting all the time. So we started off with 50% mortality, and without a plan, we were just transplanting patients. And this was when I was the junior. And gradually we realized that the actual planning and the actual planning of the setup are really important. So instead of just firefighting, then you actually have to make a decision and sit down how you're going to do it. I know that other units have visited our unit, and we visit other units to see what different people do. So I think it has to be completely intentional from the start, particularly if you're starting a new program, as opposed to just falling into it.
Thank you. You have a very interesting question in the chat from Innova Children's Hospital. If people have had any experience in using clips, AV valve clips in failing Fontan with moderate to severe systolic ventricular dysfunction. I was wondering if anyone has any experience with that.
Well, actually, as a surgeon, I don't have so much experience with transcatheter procedures. In the literature, actually, there are just case reports. And in our center, and in our experience, even if we have a large hemodynamic experience through cardiologists, actually, we never faced the case of mitral clip implantation. Also because there are some technical problems, you should consider the anatomy. Sometimes you have to move into the AV valve position. You have to make very complex catheter movements, and so I would consider it as just a palliation, which by the end, of course, is not the solution.
Yeah, in my limited experience, like already you have moderate dysfunction, and you're gonna clip that valve that is probably offloading that ventricle. Like that ventricle is probably also not gonna like it. So another question from Dr. Buchek. How does your program time EP collateral closures in regards to transplant from a surgical aspect? Are the coils a hindrance?
This is a good question, because ideally, I would like that every month the patient would undergo a catheterization to close all the collaterals he or she has, but of course this is not possible. Usually, I have to say that our cardiologists, congenital cardiologists, are extremely efficient. Once we list a patient for transplantation, they perform at least once every 6 months a catheterization, and we try to close the most collaterals we see. Ideally, what I think is that if you are able to perform a transplantation in a hybrid operating room where you also access to transcatheter procedures, probably that would be extremely useful intraoperatively to try to close those collaterals that you were not able to close preoperatively or surgically during the sternotomy. But to date, this is just, an ideal strategy, which probably in the future we'll have to implement.
Yeah, I agree. All our patients that we assess for transplant undergo cardiac catheter and aortogram as part of that assessment, and they're all consented for embolization of AP collaterals. One of the biggest markers of mortality post-transplant for us is bleeding, and so we're fairly aggressive. And the way we do it is we use particles to embolize the collaterals initially, and then backfill that with coils. But the particle is fairly important to make sure that they're embolized distally, because you can get other collaterals which will develop, and if you've got plugs too proximal, then you can't get past them to embolize the distal vessels. So we're very aggressive. We take them back several times, and if we don't, we certainly hear that from the surgeons. I suppose the other aspect of that question is cyanosis is mentioned, and we never find that embolizing collaterals changes the saturations. It never worsens the saturations, because there must be some increased efficiency to the Fontan circulation when you've embolized the collaterals, and it always pays off, in my experience, very evenly. So occasionally you get hemoptysis afterwards, but really I don't think embolizing the collaterals really has a significant impact on the saturations.
Dr. Walls has asked, could you share with us your experience, that maybe for Anitra and for David, could you share with us your experience with pulmonary vasodilators in Fontan failure and what patients might benefit?
Yeah, I'm happy to take this one. We have a screening program at our center where we're kind of looking at a combination of things, right? Elevated transpulmonary gradient in addition to low cardiac output and poor exercise tolerance. Certainly, those ones are a slam dunk for as long as the EDP is not as significantly elevated for starting pulmonary vasodilators. And then following that up with then a repeat VO2 study to understand, has it truly improved exercise tolerance? And in the right selected patients, I think it can. I think we can come into pitfalls where we are throwing medicines at patients who have, say, elevated elevated EDPs, for example, or patients who are not properly followed or who have extensive liver failure. And some of the pulmonary vasodilators can become more systemically absorbed and decrease the SVR, depending on the physiology that you have of your failing Fontan, and can actually hurt. So I think in those situations, we tend to avoid those, but that's basically been our practice at Stanford.
And just a quick follow-up to that, what vasodilators are you using?
Certainly starting with the PD5s, I think makes sense. I think when you're getting into dual and triple therapy, there are clearly other things that are up against the wall. That you are suffering in many other ways. So generally not having patients on triple therapy and things like that as we would our regular PH patients, but starting with PD5s, given at least the data on that.
On that nature, I might just follow up myself, if that's okay. I hear from pediatric cardiologists who are able to use triple therapy or just PGI2s in these populations. I do think that our pulmonary vasculature we're dealing with in the adult population is somewhat different. Do you think that's a fair assessment?
I think it is different. I think what we're finding in the, and you may be finding the same thing, is that there's a number of, especially in the lung distribution, right? The arborization that we spoke of sort of early on, and that maybe doesn't come to bear later on in the apices, for example, of the lung. So that potentially VQ mismatch and things like this could become an issue. I'm sure you might be finding the same thing, Kate. But yeah, I think that the adult pulmonary vasculature is different in terms of how over time, maybe lack of recruitment in certain areas, you pay the price.
Absolutely. Dr. Hickey has asked an excellent question about, it's kind of relevant to all speakers, be interested in the European, the UK and the US experience in 3.5 minutes on heart alone versus heart liver and the impact of liver health, regardless of liver health.
We're trying to move away from heart liver. Heart liver is very difficult to deliver in the UK, and recently we've had 2 patients who were on the heart liver list admitted on long-term milrinone, and we reassessed their liver, and they'd become well enough, we thought, for heart alone transplant, and both had heart alone transplant in the end. So the liver recovered enough, but that's because the donor allocation to get a combined block is really difficult in the UK. We've also looked at the data of some of the centres who are doing heart liver for all Fontan patients. So Fontan equals heart liver, and firstly we can't deliver that, and secondly we would definitely do heart transplants alone in most of the patients that those heart liver for all Fontan units would do a heart liver in.
That's in our experience. For years we just transplanted the heart alone, and in the last years we started to assess post-transplant the liver with, I would say, interesting results in terms of changes of the liver, also with biopsies. We listed in the last 2 years few patients for heart liver, but to date we just performed one heart liver in a very bad patient, and the outcome was not that good. The thing is that when you start a similar program, you might take into consideration that sometimes outcomes are not that good. Even if you plan preoperatively these patients in the best way possible, with pathologists, with liver surgeons, liver transplantologists, you have to accept also bad outcomes. You never accept that as a surgeon, but from these bad outcomes, you can learn something which can just improve your future combined transplantation, I guess.
I would say the same thing at Stanford. Naturally, we have assessed and listed and transplanted heart liver. I think it is harder. It is more challenging. It does kind of as a marker. It represents a marker for a sicker patient, right? Because if you can get away with heart only, you would have done it by now. But it's always hard to skirt the heart fails first and doesn't have impact on other organs kind of situation. And especially in the older patient, it's just time from Fontan completion in terms of that impact on the liver. So I think it's tricky.
We're almost at the hour. Thank you to all the speakers. Thank you to Kate for moderating the session with me. I wanted to bring up 2 points, one being the special interest group that I mentioned. Please do join. I hope that this webinar will stir some more conversations and cases that you can exchange on ISHLT Connect. So please do join the special interest group on ISHLT Connect and share ideas. And this year's ISHLT Pediatric Masters Academy is actually a congenital Masters Academy that will be dedicated towards care of congenital heart disease patients from birth to adulthood. So it would have a lot of exciting ACHD content. So please do try to attend the ISHLT pre-conference day Masters Academy. Very grateful for all the ACHD champions for taking over this pediatric professional community webinar. And we really hope to keep the conversations going. Thank you.